Lovely. Thank you very much once again for having both Enda and myself over here. It's very kind of you and nice of you to listen to me twice. Hopefully I won't bore you too much, but we're having some same slide difficulties. You couldn't just move the slide up for me. It's always a challenge following such esteemed speakers as this morning, because I'm trying to paint a picture that groin pain is solved, everyone's in agreement, and therefore what's all the fuss about is actually a challenge, and it's probably misleading. Many of you will have seen this editorial in JSPT with Jeremy Lewis, who argues a pretty persuasive argument that actually one of the big problems that we have in sports medicine is that we're trying to medicalize normal changes. And I'd like you to think about that as I sort of talk through what I'm going to try and steer you through today. Don't think I'm going to. Could you just knock the slide on? And one more, please. So we have to remember that when we look at athletes who develop groin pain, they're players who play sport. They train pretty hard. In rugby league here, they take contact. So they're used to being sore. So acceleration, deceleration, change of direction, all of those things they're used to. So developing pain as part of this is normal. And Bill Knowles mentioned that yesterday to us and said, you know, look, the medicalization of this, the deciding that what these people can do and can't do based on pain and pain alone might lead to us over-intervening. We might just move forward. And it raises the question as to whether groin pain is pain or is it actually pathology? So is there something we can go off and find? And next slide. Yeah, again, one change. So Per very eloquently talked us through the changes in the way that anatomy is being treated. Could we click one more as well, please? And in 2007, he produced an excellent paper in terms of his entities approach, and really was the grandfather of all the anatomical discussion behind groin pain. I just need one more click, please. Click again. Click again. In 2009, Einar Falvi and I were working in... Oh, okay. In 2009, Einar Falvi and I were working in Melbourne, young whippersnapper sports and exercise medicine physicians, and thought we could do better, which was remarkably arrogant of us. But we published another paper called the 3G approach to groin. Yeah. The 3G approach to groin. And what that did was to try to take us on a palpatory tour. So rather than try to categorize groin pain per se, we would walk around the groin with our finger and try and press on points which became sore. As you know, that then progressed further, or the world of groin pain anatomy progressed further to the Doha consensus, Adam Weir, and then described really an extension of Per's excellent entities model, which he's already highlighted. In our papers, which I'm going to talk about, we struggled to comply with the Doha consensus, because as I'll explain to you, when we press on an area and it's sore, that doesn't easily categorize under the Doha consensus. And then latterly, Ernst Schilders has added in a new confounder. He's described this pyramidalus complex in terms of adductor longus and pyramidalus, and conveniently he's found an operation to fix it. But it's yet a further question mark over in terms of the anatomy. And I don't think these conditions are any different, but how we're describing, as Per quite eloquently again put, is the challenge. But this excellent paper in terms of time loss versus non-time loss groin pain, I think adds weight to the argument that this may not be pathology, which might be why we're finding it so difficult. Because if players can continue to play with pathology, and something tips them over the edge and so suddenly they can't, then are we dealing with something which is so fragile that it can't tolerate load? Or are we really dealing with a patient, much as if any of us did 100 pull-ups? Well, actually, if I did 100 pull-ups, my arms would hurt a lot the following day, and maybe the day after, and maybe the day after. So are we dealing with pain rather than pathology. And again, this meta-analysis by Mosler highlights maybe the same thought. So you take the things of significance, so the things that differentiate groin pain, and they're pain provocation tests. You take an MRI scan and look to see whether or not you can differentiate groin pain. You can't. So let's go back to biomechanics. And so we all know that when you look at a joint, the muscle applies force across that joint, and it's really relative to either the size of the muscle or the distance from its attachment point, the fulcrum. We've all done a bit of physics. Of course, as that fulcrum moves, such as the hip joint, in a single plane, that creates a moment of inertia. And so we can look at how those muscles apply force. Of course, at the hip joint, it gets a little bit more complicated than that, because the hip joint can rotate. And so you can create both an angular velocity and a rotational velocity. So if we look at a single muscle group, we can identify those forces. Of course, it's very difficult to measure those forces, but we know they happen. And when we look at the groin in total, we can see in this lovely mathematical modeling study based on anatomical prosection that we can see there are multiple muscles pulling in various different directions in the groin, and this is assuming the groin remains static. So if the pelvis remains still, these actions still work on those force vectors. But what we've seen is that our players accelerate and decelerate and change direction. So actually trying to quantify that problem and suddenly develop pain in 1 or 2 or 3 of these attachment points remains a challenge. And why is that? So when we look at actually what happens here when someone changes direction, we can see that the lower rectus muscle and the adductor longus either oppose or don't oppose movement at the front of the pelvis. Hip internal rotation, as we saw earlier, can cause some impingement, but can also act with the hip flexor to work and the lateral hip muscles. And of course, that's opposed by the paravertebral muscles, the gluteal muscles, and the hamstring muscles. And so coordinating all of these together, we can see that actually if there is a relative strength deficit, we can see at how those patients can suddenly develop an overload at 1 or more of those sites. So trying to add to the literature, we took just under 400 patients consecutively in Dublin, and we had we looked at, first of all, how they presented from an anatomical perspective. So you can see they're pretty typical of patients. The one thing that's different with that population is most of them play Gaelic football. So that's not soccer, it's not Australian rules football, it's sort of somewhere in the middle, and I can say that comfortably because I'm English in Ireland. And so there might be something specific about the sport that makes this peculiar, but I'd argue that it's still a sport which accelerates and decelerates, changes direction, and kicks. So when we examine that group, you can see that when we poked them to find a source of pain, that we can see that some had adductor pain, some had aponeurosis pain. We'll talk a little about that in a second in terms of what I mean by it. But some also had pain on adductor squeeze, and they also had decreased internal rotation. So what I mean by aponeurosis pain, and we categorize a lot of our patients in this group into having pain in the aponeurosis, is if we imagine we're examining the right leg of a patient, and we palpate up adductor longus to the adductor tubercle on the pelvis, and we can feel the adductor move into place. If we move superior and slightly medial, we could reproduce pain at that site, which is over the pubic bone, but not the symphysis, and not far enough up to be in the rectus abdominis muscle. And I'll hold my hand up and say we probably don't know what we were palpating. Do I think it was pyramidalis? I don't know. Do I think that pyramidalis can be responsible for pain to stop someone playing? I would argue probably not. But that's what we refer to in terms of that aponeurosis pain. Every patient had an MRI scan. We were very fortunate, but as you can see, each of those patients had multiple pathologies. So it was quite common to see bone edema. It was quite common to see what we refer to very much of Zoger's MRI work in terms of the sagittal view, some separation of what is that structure over the front of the pubic bone. But it was also quite common to see some hip pathology and also some adductor pathology. So the MRI didn't really help in terms of discriminating what we felt was wrong. We measured Hagos in our patients in terms of tracking rehab, and I won't move further on this because Ender's going to talk about that rehabilitation. I'm going to focus a little bit on biomechanics. So we took that group of patients, and before we did anything to them from a rehab perspective, we used reflective markers, and we digitized their movement in 2 cuts. So one, which we called a decision cut, which is a 5 meter by 5 meter by 5 meter triangle with a 110 degrees cut, and the patient performs it 5 times to the right, 5 times to the left. We then have an indecision cut, where the patient runs towards a force plate and then is triggered left or right by light gates. And we took that data because we felt that it might represent what happens in a propagating movement in a patient with groin pain. And what we found when we did the modeling work to look at how these were distributed was that they distributed into 3 very distinct clusters. And you can see the distribution of the patient population was different across. So about 43% or so were in cluster 1, fewer were in cluster 2, about 13, about 45% in cluster 3. The percentage numbers refer to the amount of work done by each of the joints. And so you can see that there's some difference in work, particularly at the ankle, knee and hip in those groups, and I'll talk a little about how that differentiated in a second. But also we can see that there were some different kinematic variables, and I'll show you that in a second. So cluster 1 had features of hip flexion, It's a bit afternoon. Yeah. Yeah. I should build it. So you can see there was some. No. We'll stay there. We'll come back to it. Yeah, we'll come back to it. So at this point, there were some differences in kinematics. I'll talk about them in a second because there's a different slide. It's easier to see. So here we look at the relative predominant joint. So in cluster 1, we can see that that was predominantly ankle. So the power in cluster 1 came from the ankle. In cluster 3, we can see that the power predominantly came from the knee. In cluster 1, the power came predominantly from the hip joint. Now remember, these are in a single point in time. They're at the foot contact of a change of direction, and they look at that change of direction moment. So that's not step by step, and that's not every movement. That's not when they kick the ball. That's we're predefining a condition by which we look. So what kinematic variables differentiated the cluster? So in cluster 1, we could see decrease in thorax counter sway. So the upper body was more stiff, was more upright. And we can see there that there was a decrease in ankle plantar flexion work. In cluster 2, there was an increase in thorax sway. Now these are the main features. There are obviously a bunch of other features, and we'll talk a few bit about them in a minute. But in here, there was less knee abduction. And then finally, cluster 3, again, thorax counter movement or thorax sway seems to be important. Knee power obviously is. But what about the diagnosis? So when our hypothesis originally in this study was that we'd find a movement pattern which conveniently fit with either adductor pathology, hip flexor pathology, inguinal pathology, or rectus abdominis pathology. But as you can see here, they were very evenly spread. We spoke briefly yesterday about the new work that's coming out in looking at cluster analysis in injured and uninjured runners, and find very similarly that cluster membership is quite common, but it doesn't necessarily associate with an injury type. And we were a little disappointed by this because we thought we could therefore use an association with injury type in order to target rehabilitation. But is cluster membership consistent? So Adrian was one of our biomechanists currently at University of Bath, looked at the maintenance of cluster membership. So he took a bunch of normal patients and a bunch of groin pain patients and asked them to perform the 110-degree cut 15 times. And what he did was then analyze whether or not the patients clustered in the same way across that 15 times. So was there a fatigue effect? And was there a difference between those that clustered with groin pain and those that clustered who were normal. In order to do that, what he really did was take a resultant vector for each of those joint centers to try to reduce some of the muddiness around the data. And what he found was actually cluster membership is consistent. So if you're in a groin pain cluster, you remain in the cluster. And if you're in a normal cluster, you remain in that cluster. So even as you fatigue, those features, the variables associated with that movement, remain consistent. And we can see on the left of the screen there that in the groin pain group, of this which is a new group, 65% were in cluster 1, 20 in cluster 2, 15 in 3. And that, in the normal group, you see is very much more evenly distributed. Does that mean that cluster 1 developed groin pain? Well, I've no idea, because we've not done the prospective work to see. And it probably isn't true, because that cluster membership still talks about capacity. So why do you belong in a cluster? Well, you belong in a cluster because of a number of features, and we're going to talk a little bit about that. So yesterday I tried to explain the principles behind supervised learning techniques. So remember, these ultimately the data originates in a patient. So although it's a math technique, it starts with real people. So again, we take a whole load of variables, we look for commonality in the variables, we discard the variables that have commonality, and we examine the outliers. So we examine the things that differentiate between one patient with groin pain and one without groin pain. And then we try to strip down the features, having picked a model that best fits. And as we strip down those features and try to get the smallest number of features which correctly identify whether a patient has groin pain or not, we left, in this case, with 5. And these all-important 5 features start with hip abduction angle. So the hip abduction angle, when added to thorax frontal sway, added to ankle plantar flexion moment, added to ankle rotation moment, and added to hip flexion angle, could correctly classify whether you remained in a patient group with groin pain or a patient group who were controls. So that's exciting for us, because that suggests that although it's not predictive of developing groin pain, that the cluster membership remains consistent, and the cluster membership can differentiate between the two. So much as I spoke about yesterday, rather than saying this is all about knee flexion angle or hip internal rotation or hip adductor moment, and about how much force we can produce, this is about the combination of those variables that add up to a scenario that suggests that there's a target for rehabilitation. And we can see the consistency of those features as we move along. So that little area box plot on the bottom right-hand side shows the consistency of membership. So the more fuzzy the data is, the better it is for us. It shows a stronger association. We're more confident. So about 70% of patients are correctly identified. So what does that really mean in terms of groin pain assessment or rehabilitation? It really gives us a target for potential rehabilitation. We can differentiate our patients with groin pain, regardless of what they feel is sore, into a group which gives us clear parameters in terms of rehabilitation. Enda's going to talk a little bit about what that does to those movement patterns. The single joint variables aren't reliable enough for us to say there is one variable that matters most. And actually, you would question my sanity if I was saying that. And the clusters don't cause groin pain. So clusters describe multi-joint coordination and provide us a target of things we can approach. And cluster membership gives an ability to pick those features directly. And I'd liken it to, rather than starting in chapter 1 in the book and working all the way through to the end, it ought to allow us to say, well, chapters 6, 12, 14, and 21 are the personalized targets which you ought to concentrate on, rather than the whole bigger picture. And we can target those features in order to try and change that membership. So in summary, I'd like you to question whether the pathology matters. Have we medicalized this to an extent where we're looking for something wrong? And does that explain why there are multiple groups who can't agree on what's wrong here, and there are multiple surgeons looking for the perfect fit to try to intervene? Are we medicalizing overload pain? So therefore, can we train this and can we reverse the effects through just training the pelvis or training our athletes better? So provide a target. Does biomechanics provide that singular target in order to focus on and do something very quickly? No, it doesn't, but it should allow us to shape rehab in a way that's very different. And is clusters the answer rather than looking at single features? I'd argue it was. Thank you very much.